Well, thank you all for the invitation and to the organizing group for allowing us to have a conversation. Some of the issues that were just mentioned in the last session will be pertinent to what we're talking about. And I think in many ways there's so much overlap. I know Dr. London, Dr. Henry, there's a variety of other folks here from other institutions that have comparative cancer centers that have been evolving over time. And in actuality, the clinical study of naturally occurring cancers in companion animals, particularly in dogs, has been ongoing for 35 or 40 years in very structured ways and has been supported by NCI for most of that period of time, as well as other funding agencies. So, the type of integration of cancer centers into the NCI Comprehensive Cancer Center program takes many shapes and forms over the breadth of the United States. And so some of it will be very informative for us to actually have these conversations and open up some of the discussion with Dr. London, with Dr. Henry, and anybody else that is representing some of these cancer center academic partnerships. I've already met the other two panelists, Dr. LeBlanc and Dr. Gilbert. So I think one of the ways that we could begin this is to perhaps quickly review what the resources are at COP. This has created a tremendous opportunity for the cancer centers to be engaged in multi-center trials and provides a significant amount of support. So maybe in light of some of the conversations that we just heard, Amy, just sort of review again.
So the Comparative Oncology Program has a clinical trial consortium as one component of our program's mission. The sites are 20 in number at this point. They're all united by a memorandum of understanding. As far as the agreement is structured, there's clear language on how the clinical protocols are developed, executed, and managed, the relationship between the study site, the COP, and then the study sponsor, which is typically provision of study agent and a funding source. Although some of the studies that we're about to get into later on this year and for the coming years, that may not always be the case. So there's a little bit of flexibility there. So the sites are united under that memorandum, and it's signed every 4 years. It goes through occasional updates and edits. And when we work with a sponsor of a trial, we work very closely with them within the COP personnel to define the goals of the study, whether or not it is feasible within our network. So we keep really good contact, I hope, with our sites and sort of get a feel for caseload and access to certain equipment. Imaging devices, for example, are not necessarily the same across our sites, but we maintain a certain level of requirement for participation in the consortium as far as personnel goes. And once we get to a point with the study sponsor where we feel that the consortium's infrastructure and current resources can meet their needs, and that we have a rational reason to include a naturally occurring dog model in the questions that are being asked within the drug development path of their agent, we then write a letter of intent. That letter of intent is then circulated throughout the sites and asked again whether specific sites want to be included or not. So that gives the sites the ability to say, yes, we want to be involved, or no, we feel like we have competing efforts in this area, or no, we just had people leave and we're not necessarily an active site right now, or whatever the case may be. And so then from there, the letter of intent evolves into a full protocol with standard operating procedures, appendices, a standard consent form, and a budget. And then that package goes back to the sites. The sites then seek internal IACUC approval. And they also, in parallel, execute a contract and an agreement to receive funds from the study sponsor directly. So that process of getting a contract signed and having the IACUC approval documents in hand can take anywhere from 4 weeks to 12 weeks or longer. In the standard MOU language, we have a requirement for what the sites need to be able to provide as far as the amount of time to turn things around from a grants, contracts, and IACUC standpoint in order to be active members. And that just helps the process not get slowed down. And our sites really do an amazing job of keeping up with all of that paperwork. And then the study is executed, and then we use a C3D, the remote data capture system that's administered through the NCI. So there's a C3D database that's purpose-built for each trial, and the sites enter data in real time, and then that data is pulled and reviewed with our study sponsor on a regular basis. We convene adverse event reconciliation calls and also convene a data safety monitoring board for each trial. That consists of a chair and then members from the consortium that are not participating in the trial so as to mitigate any conflicts of interest. And then there also within the MOU, there's a provision for publication and dissemination of the data with a joint sort of agreement on the venue and the timing of how that data will be disseminated. So that gives you sort of an overview of how our clinical trial network operates. We've had 11 studies to date that have gone all the way through completion. We have a collection of publications in +1, and we have 2 papers that are in press and 2 ongoing clinical trials right now, with 2, possibly 3, getting ready to kick off in the next 12 to 18 months. So we rely very heavily on the sites to be engaged and understand that as our program has become, and really thanks to Chankana having started it 10 years ago and now passing the reins to me, I mean, we've had a lot of success, and I think we start to see that success build within the sites that participate in our network. And so now we're at this sort of victim of our own success moment where there are going to be competing efforts and only so many cases that can be naturally handled at each of the sites based on their technical support and their ability to just get the cases in. So having really well-staffed clinical trial offices like there is, at Ohio State and others, CSU, being just really good examples of that. Those are the efforts we need to then support if we are really going to have a comprehensive set of clinical trials that are available that satisfy not only the internal scientific demands of the sites, but also the larger comprehensive sponsored trials that we run. So.
And most of the trials are sponsored by pharma or
so it's a
internal?
mixture. Yeah. Some of them have been internal, intramural NCI supported. We've had studies that have been sponsored by pharma. We've had the Morris Animal Foundation has been a really remarkable partner in funding some of our work. So I think that it's a good example of where we've been able to take a fairly straightforward yet concrete mechanism and then try to adapt it to meet the needs of how the landscape changes, particularly from a funding standpoint.
Thank you. And I think it's relevant to also make sure we understand that the COTC is funded to support these clinical trials for the benefit of human health. And that yes. In many instances, that can be equally important for animal health, but it's not the mission of the COTC. But the resources that have been built and the ability to manage these multi-center, sometimes very elaborate sampling trials is really phenomenal. So I think there's a lesson that could be modeled from the type of investment that's been made, relatively small investment comparatively, I think, to be able to populate a clinical trials office at a national level and to be able to pull off multi-center trials. So, each of the various cancer centers around the country and many of the academic institutions have their own emphasis in cancer. And there are several very significant private practice or specialty practice types of institutions in which they also do clinical trials and participate sometimes in single institutions, sometimes in their own multi-institutional trials. But those are generally done for the benefit of animal health. And I think a lot of the similar infrastructure is built and is paid for. It really takes a tremendous amount of resources to make a clinical trial component like this sustainable. One of the things that was just mentioned in the last session was a biorepository, and Amy mentioned this morning that the Canine Comparative Oncology Genomics Consortium is also overseen by the Comparative Oncology Program. And that was actually a concept that was funded about 6 or 10 years ago with the intent to build a tumor archive with samples from the most common cancers and from cancers that would be of interest to pharmaceutical industry development. And an investment of over $1 million was made to populate this. And the COP ran the collection of the studies and collections of the tissues, and really did a fabulous job. And those samples are available. So you want to make a pitch for how to access those for all the future studies that could be developed in this.
It's right up the road in Frederick, first of all, so sitting there quietly waiting for someone to come claim them and bring them home. So the strengths, and really Christina Masco, who's here in the audience, is our program manager, and she was really the person who I think on a day-to-day basis is the one who really makes sure that the CCOGC functions appropriately. So thanks to you, Christina, in the back. The CCOGC is populated with really high quality specimens from dogs with treatment-naive cancers of specific histologies that were, again, chosen strategically because of their relevance to human cancer. And so not only is there tumor tissue there, but there's normal tissue, blood, urine, plasma, serum, and all of these tissues are collected in a very specific manner according to very strict SOPs, and then held not only in formalin fixed tissue for paraffin embedded and subsequent H&E and other IHC opportunities, but also for genomic and other assays. And so right now, the idea is to make sure that now that this repository is replete and clinically annotated and known to have a high quality, so the QA also, I'll give a nod to Mark Simpson's group here and Matthew Breen's group, who helped us really ensure that what we had collected was of high quality, and we have all the clinical data annotated from the patients. Now we need to get these tissues out into the community. And so the CCOGC has made a move now to remove some of the perceived barriers to getting a hold of these tissues with respect to scientific review of proposals. And so I encourage you to visit the website, speak to myself or Christina about some of the specifics if you're interested in getting a hold of anything that's in the bank. We'd be happy to assist you in that.
So I don't want to leave Dr. Gilbert out. Yes. How about, can you maybe look ahead and made a very compelling argument for the use of canine primary brain tumors this morning. The nature of collecting brain tumors is not trivial. We don't have collections now that I'm aware of in very many places or very many samples. So the value obviously seems high. Is that?
I think it's, well, let me first start off by saying it's this whole concept of integrating veterinary and human medicine together is just unbelievably appealing. And when Amy first approached me, it was almost a eureka moment. It's like, yes, this is so obvious as to be amazing, and why haven't we done it? And actually have communicated with several colleagues, and we seem to be following the same geographic path around the country. And at least on the human side, everybody has the same, experience, the same revelation. We have struggled for decades, at least in the primary brain tumor field, of not having very good models. And it's not through lack of effort, certainly, to the point now we're doing incredible genomics, and now there's new genomic technology with CRISPR, and you can essentially make the genome look like anything you want it. But if you then put that into a model that Amy pointed out is this big, and say, how does this reproduce the human condition? If you are comparing a brain that's this big with a 4-centimeter tumor, I don't think you really have to stretch it to realize that there are limits. So I think from a global perspective, having this partnership is really amazing. We have done so much fundamental work on the human side in understanding the biology and the molecular changes and the pathogenesis that it would be very easy to take all of that collective experience and very rapidly ramp up the canine side. And it is just a matter of getting those tumor tissues. The platforms exist. We have gotten so sophisticated, there's virtually nothing that we cannot do off of paraffin-embedded formalin-fixed tissue, which is a big change even in the last 2 to 3 years. So when we talk about these large-scale clinical trials with molecular stratification and asking, questions about enrichment and targeting particular tumor subtypes, we do it all on paraffin. And so I could envision a scenario where, through a collaboration, we create a tissue bank and have a consortium of human and veterinary pathologists working together and reproducing a lot of the work that we've done in human brain tumors. I'm heartened by the fact that we took a rare disease like ependymoma that I talked about this morning, and we're able to get, it turns out it was 715 clinically annotated ependymoma samples for a disease that is really rare. And if we can do that for that disease, I would argue that we should be able to do that for primary brain tumors in canines and allow us to ask the questions, do these diseases recapitulate adult human cancers or pediatric human cancers or some amalgam in between, but get us started in asking hypothesis-based questions in parallel. So I think the opportunity is there. I think that there's a lot of our experience in creating those types of environments that, it's, to quote a Clint Eastwood movie, there's the good, the bad, and the ugly. But there are ways of creating a collaboration that is sort of universally beneficial and I think incredibly productive, and I think gives everybody an opportunity to participate, not only in providing material, but then benefiting from that material. Either a centrally stored data repository, like they did with the TCGA, that's public access. And so if you have a particular idea and you want to see whether there's any substance to it, you can go to the TCGA database and ask the question in any of the cancers that the TCGA has investigated. And I would argue probably want to do the same thing with this. So I think there's tremendous opportunity. I think the way has been paved. I think a lot of the growing pains have already been experienced. And I think it would be a much more rapid ascension to a very extensive and very fruitful collaboration. It just makes so much sense that I'm excited, and I was really excited to participate in some of the meeting today and hear the level of science that's going on in a collaborative
You might need to
basis.
go back and get a veterinary degree. You're sounding like one of us now.
Maybe. I'm thinking about getting a dog. Does that count?
Yeah.
Okay.
Yeah.
Talk more about that, yeah.
So looking forward, I think there are some things that would be very important for us to consider. And part of the reason that the Institute of Medicine workshop was organized and promoted was that we do want to look at the field of comparative medicine from a perspective of what are some of the gaps that we need in order to move forward, not only from the standpoint of some of the science, but also some of the regulatory and sort of policy issues, which is obviously the IOM's purview. So the IOM workshop is, as was mentioned, will be taking place June 8th and 9th here in Washington, D.C., downtown in the National Academy building. And there will be a series of agendas taking place over about a day and a half, much like this one, which will try to identify what do we need, what are the gaps. I think some of those gaps we've already begun to understand, and one certainly I think would be a canine cancer genome atlas. for the majority of tumors that seem to be reasonable correlates for human cancers, but there's truly a lack of canine-specific reagents, and in particular monoclonal antibodies that might be used both for diagnostic and therapeutic purposes. So there probably needs to be some biologic developments in order to create a toolbox that's a little bit bigger for us to move into the space where we need to be. And I think one of those spaces is the fact that we believe, and there have not been sufficient number of examples to actually provide the evidence, but we all sort of intuitively and empirically believe that companion animals with naturally occurring cancers, our patients, can provide extremely important value to the development of new products for people and for dogs. And much of the work that's been done to date has been driven by sort of co-parallel efforts in both of those areas. So there'll be a number of different things that I think are important for us to consider. How to do clinical trials faster, more effectively was a source of some of the discussion earlier. And I think the ability to provide some of the oversight and guidance for clinical trials so that we know that they're uniform. Almost everything that was mentioned that CTSA program builds, I think we should probably think about building ourselves, except maybe the centralized IRB. And we can consider talking about that, Sue.
Yeah, I had a question because it appears that the field of oncology is advanced in this collaboration beyond other areas where there's definitely overlay between the human and animal diseases. And I'm just wondering on your thoughts about why that might be the case, whether it's sociological or opportunistic or number of cases, et cetera.
So that's an excellent question. I've actually wondered that myself because there are so many excellent examples of stories to tell where what veterinarians have observed to occur in dogs is not any, older, newer, or different than what we've observed. So, for example, like infectious and zoonotic diseases, we've observed those things as veterinarians for decades, maybe longer than we've really appreciated and understood what dogs develop with respect to cancer. So, I'm not sure necessarily how to rank the factors that have influenced comparative oncology kind of coming out. Probably the NCI's support of this program and the hard work of Chan Khanna and everyone who came sort of behind him and around him, and the work that we did within the COTC sites to really raise the visibility of the work we did. I think that helped. But I also think that there just aren't enough maybe national forums to disseminate this knowledge. I mean, I think that the toxoplasmosis story that I've heard come out of the Davis group is probably one of the most compelling, and just it's a really intriguing story to tell, where you see the really amazing intersection between people and animal populations and natural marine ecosystems and urbanization and just all these amazing things that come together to tell a really compelling story. That needs to have more of a national stance, and maybe cancer is just one of those things that just gets a lot of press and people are less psyched about zoonotic diseases. It's hard to say, but I think that we have an opportunity to just show what we did and then help others who may need to follow the lead or take a page from our playbook. If we can help in any way, I think I'd like to see that happen.
Maybe I could make a comment. So since Nixon launched the war on cancer back in early 70s, right? Mm-hmm. They set up the clinical cancer centers and translational, the comprehensive cancer centers. And so cancer, for right or for wrong, got off the ground early. And I think in many ways, the CTSAs that were established were designed primarily to do for all the other diseases what we've been doing in cancer for maybe 20, 30 years. And so I think maybe the reason, to answer your question, is that they got funded, they had money, and they did it, and it was a natural alliance with some of the studies in animals.
But I think on a global scale, when you think about what really impacts global populations, cancer may not really be at the top of that list. right? I mean, we really need to be looking more at infectious diseases and emerging pathogens on a global level.
Well, just go to China. Just go to China. See what you see there.
Global level. I mean, coming to this conference, I mean,
Yeah.
I do
Number
what I do,
one
and
cause of death in this country for people dying under the age of 85 is cancer. So it's a problem. It's going to be in China, India, all these other places too.
Is there, Michael, you want to?
Yeah, just give maybe for Amy or Rod, the Veterinary Cancer Society has a list for clinical trials. How does that group's clinical trials list, and how do you interface from the comparative oncology group with that? Or there overlap or?
It's
Go
managed through the University of Missouri.
Yeah, actually, yeah.
And I think it's a great resource. So Carolyn may be able to provide how the operations of that work. But I know that all the trials we run, whether animal or COTC or pharma, are uploaded into that database very easily. I think perhaps a trials.gov correlate would make it cohesive and integrated a little bit more, so that there'd be some of the same oversight and perhaps some of the same requirements for listing a clinical trial that currently exists in trials.gov. But the one that's most often reported is the one at Missouri.
And I'll just add to that. I just had a paper in European Journal of Nanomedicine about animal models and trials, and I have a table in there that lists every site I could find that relates to clinical trials in companion animals.
Yeah.
I think there are about 8. But what I am finding is there's a lot of cross-referencing, and most of them tend to go back to the one that's through that cancer trials.
Yeah.
So I would also advocate, because I think as an investigator in humans, if I knew that there was a study going on in canines, I would contact those investigators, and why not use that information?
Yeah. Create a network of collaborators right
Exactly.
off the bat. And Debbie?
I was just going to ask, do you find, and this is for the MDs, do you find that when you have patients who've had pets in clinical trials, that the curve to getting them to participate in a human trial is faster? Because in some sense, it's an education for them to have their pet in a trial. And I know accrual and getting people to sign up is sometimes a challenge.
I don't know of anybody who's ever looked at that particular question.
I think probably a handful of times people have talked to me about having a pet. And I think it's a really good question to ask, because we are now in the context of recognizing the challenge, as everybody probably knows if you watch The Emperor of All Maladies, 5% of adults with cancer participate in clinical trials. And everybody says, why aren't we making advances? Well, it takes us years instead of months to accrue. So we are in the process of trying to come up with strategies to break down the barriers. I think there's a lot of distrust, and if you've had an animal on it, we should actually do that. We should ask, because a percentage of patients who have had animals on trials will have had cancer. I think it's a really great question.
Thank you again. I think we'll pick up over the break.